and to move on then to item 5 on the agenda, which is the presentation by Jane around transforming care for people with learning disabilities. Jane, over to you.
Thank you, Michael. So I've got a few key messages that I think it's worth sharing with the board. And the first one is that we are seeing a reduction in the number of inpatients that we have at the moment, which is positive. We are seeing a reduction in the number of admissions and an increase in the number of discharges, which is in the right direction. Of the patients that were inpatients in April 14, 30% of those have been discharged, and a further 13% have been moved to more appropriate inpatient settings. So we are seeing that significant shift. The board will know, and I've talked previously about care and treatment reviews that we established last year. We've now done over 1,400 of those. What's been very interesting is not only has that prompted and encouraged discharges, but it's also identified a number of key issues that we are tackling on a case-by-case basis. So as an example, for many of the reasons why patients who we thought could be discharged but weren't, gaining agreement on a suitable plan was one of the key reasons, and that was based on having clinicians agreeing with families, with our reviewers, that it was appropriate for people to be discharged and into what type of service. We also found that there was a lack of community support, so the right provider or the right staff in the community to be able to support people out of hospital. Some patients were subject to Ministry of Justice orders and restrictions, and that in itself meant that there were some delays in being able to discharge people. All of that has given us a significant amount of information in order to support what we're doing, which is developing new models of care. So we are currently working on a new commissioning framework which will look at new standards, new models, and we have a plan and we will deliver that new model in July. Alongside that, we are identifying fast-track communities. So in a similar way to the vanguards that we have for the new models of care for the 5-year forward view, we're going to have 5 fast-track communities which are based around the areas that have the biggest inpatients. So around the hospitals where about 29% of the beds are currently situated. With those fast tracks, which will be health and social care combined, we are expecting there to be transformation plans developed over the summer, submitted to us in September, and alongside that developing an improvement programme similar to the one that we've got for the vanguards, which I know Ian will talk about subsequently. That will give us the collaborative learning, the best practice, and the lessons that we can then use to influence and implement in the 16-17 planning round. The other key message I want to be absolutely clear about is that we have committed publicly and reiterate that by autumn we will have closure and reconfiguration plans around those regions where those large providers are based. And we will then be able to implement some of those plans as for the latter part of this year and into next. I also wanted to point out the work we're doing around stakeholder engagement. It's absolutely critical. This is a really good system where we need to do this in co-production and work alongside key stakeholders. We've established a reference group which is chaired by Professor Tony Holland, who's a psychiatrist and an academic from Cambridge University, and he and Scott Watkins, who's an individual who has got learning disabilities, are co-chairing that reference group. Supporting that reference group, we are creating fora, which will be one for commissioners, one for providers, one for patients and carers, and one for clinicians. They will help co-design and engage with us as we develop that work. We have got an inaugural Learning Disability Forum meeting, which is being established on the 16th of June. The letters for that are going out today. And that sits alongside what we've got an LD Awareness Week, where we have an event both in London and in Leeds, which will be for our stakeholders, but also for NHS England staff. The plan for that is that we work with and have marketplace with people like MENCAP and Challenging Behaviour Foundation, carers, patients, that really help to establish and to tell the story about why we're doing this work to all of our staff, not just to those that are involved in the programme. I'm also pleased to confirm that we have now employed a couple of people with a learning disability. One of those is supporting the patient engagement team, and the other one is supporting the care and treatment reviews and improving lives team. So we have done what we said, which is that we would actually directly employ people with a learning disability in NHS England. I have to say it's not been straightforward. It's when you actually start to do that, being able to use things like NHS jobs, to be able to design both job descriptions and application forms in easy read, and being able to organise how those jobs are graded and banded, is difficult because it's not the same principle that we would usually use. Having done that, we've learned quite a lot of lessons, and those lessons we're using to support the work that Ian and his team are doing around wider employment across health and other sectors. So that's been a very quick summary of where we are, key messages. This is a very complex programme, but I think is one that we have got a good grip on. We know that the NHS is a complex organisation. Health and social care is complex. We are able to deliver that and have managed very complex programmes in the past. So we are committed to that delivery, and it's very clear from some of the evidence we've got so far that we are making progress, but we know we've still got more to do.
Thanks, Jane, very much for that presentation. I think we're all impressed by how much we can learn by actually employing people with learning disabilities and the adjustments that we need to make to our own processes. But can I take you back? I mean, the board is absolutely determined on as prompt delivery of this programme as we can get. And I guess what concerns me still is in paragraph 4, the CTR, post-CTR review patients who don't need, by definition of the CTR, to be in hospital, but for whom a discharge plan still can't be put into place. Really, I think we need to understand rather more what are the factors that are inhibiting us getting from the CTR to the discharge from hospital that we seek, and to what extent is this conflict of interest, vested interest, bureaucratic delay, or to what extent is this strong clinical reason for the failure to discharge?
I think the answer to that is that it's mixed. So you need to look at this on a case-by-case basis. So there are some cases where there is a lack of agreement between the people that took part, that actually did the care and treatment review, so the clinicians that came in, the commissioners from local authorities and CCGs that went in, the experts by experience that went in, and then what the clinicians looking after the patient in the hospital may have said. So there was some difference of opinion. Sometimes there's a difference of opinion with the individual patients and families. They may not be completely certain about what it is they want to see or what services they want. We've also had issues with having staff that are appropriately trained and experienced that are available in the community setting to support a discharge. For some people there are housing issues, so we may need to, or they need to maybe purchase a house, make alterations to housing. So again, that can cause delays for the right reasons, but it's very individually focused. So what we've done in paragraph 4 is summarised what are several reasons into the things that have the biggest impact. So we know that there are that what we're trying to do is radically change the way patients are cared for, and it is difficult taking some people with us on that. Not everybody agrees that it's the right thing to do. Some families don't agree that it's the right thing to do. So we need to look at each individual patient and work through with the local families, with the carers, and with the communities around making sure that we can address some of those issues. So it's not straightforward to say it's one or the other. The vast majority of them are a combination of factors, and the experience we've had so far has been you look at each of those individual factors and you deal with each of them individually and sort out, and then you end up with the result that patients can be discharged. But the fundamental issue for me is that we can continue to do the CTRs and we can continue to learn from them and we can continue to increase discharges. The new models of care, the standards and the commissioning framework, which supports commissioners to commission the right services and enables providers to provide the right services in the right place, that's the focus, and that's what we're concentrating a lot of effort on at the moment.
So would it be right to summarise that by saying what the CTR does is decide whether the patient should be discharged, and then the subsequent thing is how?
Yes. So they
So there's a
identify
presumption.
if it's possible for the patient to be
Yeah.
charged, if it's the right thing for that patient, and then it's about looking through so what do we need to do to make that happen.
So once the CTRs reach that conclusion, there's a presumption that the patient will be discharged. And
Yes.
It's a question then of how.
Yes, and then the local teams, so the local commissioners supported by the NHS England regional teams are the ones that are supporting that process locally.
Okay. Let me invite other comments and queries. Moira, please.
Thanks, Malcolm. I just wanted to ask whether the Ministry of Justice was engaged not just on an individual case when it appears that there's an order in place, but are they engaged in the programme?
Yes.
That's good. And can I ask about the paragraph 16, 17, data and information? I was anxious that there was a data problem when we were talking about such a small number of people. And has it been resolved? It says the end of April. That's resolved. I don't really understand the kind of, there's obviously two different registers or something like that of people.
Yeah, there were two different ones. So the Learning Disability Census was set up originally, which was a provider-based census where providers were asked to submit information about the patients they had as inpatients. Of course, some of those providers had people from out of England, so they were other countries. And then the Assuring Transformation one, which is the one that we established, which was a commissioner-based set of data, so asking commissioners to determine what patients they had in hospital where. So there was a gap. That gap has now been narrowed, and we have now transferred the data collection to HSCIC. It's now, onto the clinical audit framework, it's now much more regularly done, and there is better data quality. We've still got some way to go, but there is better data quality now in terms of what we're able to report.
John.
Jane, thanks. The comments on lack of provider and lack of skills in the community is reminiscent of experience in the past with paediatrics, where one programme I was involved with managed to get children out of hospital by allowing the staff nurses on the wards to go to their homes and deliver drugs in their home and sort of cross that boundary. Is there any scope from a commissioning point of view to try and break down some of the silo lines so that it's possible to get people out of hospital into the community but continue to be cared for in part by people in the hospital? Is that an area where we could have an influence?
Absolutely. So as part of the delivery board that I chair, Health Education England are part of that. So there is a piece of work about the workforce on a longer term basis, the skills, the necessary training. But through the fast tracks, one of the things we want to do is look at how workforce can be used flexibly. So and we know that if we start to reduce the number of inpatient beds, then the staff that work in those, that support those inpatient beds, could and possibly should provide care in a different setting. There may be some training and education needs around that, and they need support to do it. But you're absolutely right. Working flexibly and across those traditional organisational boundaries has got to be the way forward. And we've seen some of that, but we need to make that more mainstream, and I would expect the fast tracks to be a really good test site for that.
Margaret, thank you.
Thank you. My question is again about paragraph 16, and it relates to the way in which the data might be used to support the cultural shift that's required with regard to management, because you indicated that some of the delays and difficulties were due to management concerns, and I was wondering about how effectively we could perhaps co-create a system with HSCIC to enable a better use of the data, so there's a systemic improvement rather than trying to seek the improvement on a one-to-one basis of understanding what's right for each individual. So there must be learns that are much more deep-seated within the system through an understanding of the evidence.
So we are working with HSCIC at the moment to look at how we can use the data that's collected to be shared more widely. In some cases we need to be quite careful. Some of this is because they are quite small numbers. We need to make sure that we're not sharing patient identifiable information. But what has been very interesting already is demonstrating the numbers of patients and the differing numbers of patients across the country, but which aren't based on anything other than a geography, because there's no other reason why we would have such diverse numbers that are inpatients. So we are doing that and are working with them. I don't know whether Tim wants to add anything extra around HSCIC.
Just to say, coincidentally, we had a meeting, in fact, this week with the Chief Executive of the Information Centre, the Health and Social Care Information Centre, to make sure that we are very specifically prioritising development of much more agile, real-time information resources to improve the way in which we plan these programmes. Again, in the context, as Jane's mentioned, of ensuring that there is no compromising of patient identifiability. So we're making progress.
But transparency is absolutely key.
Absolutely.
It's something we're passionate about, and actually being able to demonstrate that and being very clear about the improvements that are being made and the differences or variations is a very powerful way of making progress.
Thanks, Malcolm. I think 43% of the original cohort being in a better setting, either inpatient or outpatient, probably is more encouraging than we had last time. Just pick up on one thing. Where there's failure to agree, if the review team and the family are supportive of a change of setting, I'd hate to imagine that a professional or a clinical view could stop that. So is it around everybody has to agree, or is it saying, because some of the people who are used to the existing system will have that vested interest in sticking to it, whether consciously or unconsciously. So is it about everybody has to agree, or is it saying, well, we hear you, but actually the CTR says this?
That's a really good question. I think ultimately the teams in hospitals have got a responsibility for those individual patients, but we are seeing individuals, people shifting, and there is something. I mean, be honest, there is something about demonstrating the art of the possible, and actually not. And being able to provide inpatient clinicians with understanding that actually it is safe to do this. There are some concerns that are raised about, we're not sure whether it's safe for us to be able to do this. These are our patients. We don't want to compromise that. So part of what we're doing is actually effectively proving that it is safe and that we can move people, and they are getting better service and better experience and happier out of hospital. And we have seen some shifts in views and thoughts as a result of some of that. And we have got clinicians that are working with us, consultant psychiatrists that are working with us, that are absolutely committed to this and able to give very, very good examples of cases where people have been moved out of hospital, and that in itself is having a difference as well.
David, this is a dangerous question.
Oh, good.
If we've got a lot of things to get done over the course of the next few months to get to September, which we're all committed to do, to autumn. If you had a magic wand and you could wave it one or two times to change something that would give you more ability to move more rapidly, what would it be? And what help could we give you?
A bit of warning on that question would have been good. What would it be? Waiving some of the rules around transfer of funding and money. Yeah. Making it easier to flex funding. It's not impossible, but it's quite complex. So making some of that happen. And waving a magic wand and creating a really good range of community providers that are in place, that are staffed and able to take people tomorrow would be great.
And on the funds, the latter seems to be more about capability building. The former seems to be more that's in the gift of various elements of which we would be one. So is that possible to do in a short period of time? I'm just thinking about, is that something that the board could provide some encouragement and some momentum behind to make it easier to improve the lives of the people we're talking about?
We have got agreement. I don't know if Paul might want to add to this, but through the fast track programme, we will be looking at working more collaboratively between specialised commissioning, CCG commissioning, local authority commissioning. So we've got some good opportunities over the summer to look at how we can implement that more quickly. I think there is a general commitment to that. I don't know whether you want to add anything around if we could speed up those changes any quicker, but I think we've got a plan. We need to see how it works in practice.
So I don't have a magic wand, but I do have a team that's working on this particular issue at the moment. I don't think speed of getting to the solution is going to be the problem. I think once we've identified where the money needs to move from and to, actually we've got all the flexibilities available to us that we will need. The only obvious point is we can only spend the money once, and that seems to me the slightly bigger challenge in all of this. As we know, we've put aside a small amount of money as a transformation fund, small in our total context, quite big in the context of learning disabilities. But I can give the board total assurance that we will sort out the money flows to enable this to happen, as long as we can define where the money needs to go from and to.
We've also got work on personal budgets as well. So some of the pilot sites are looking at around those individualised personal budgets, and from the stories we hear from people that have had access to personal budgets and the impact that's had on their ability, and their family's ability to create a service and buy services for their family members, is actually, all you have to do is listen to that story once or twice, and you know that actually is a really positive way of making things move. And so we've got that as a pilot with the IPC pilots, and we're also looking at the other personalised budget ones as well.
Maybe that's something, Chairman, we could come back to maybe in one of our development sessions or whatever. It seems to me that those being demanding of the executive around making those things happen, and personal budgets, is quite important in unlocking some of these things.
Well, just on that point, on NHS Change Day, part of how I spent the afternoon was with families and people with learning disabilities, and what they were telling me was about the power that personal budgets had had in unlocking service transformation. And I met in particular a young woman called Claire Steeples, who described to me with her family her experience. They've got a little website that sets this out, so I'm going to give them a little blast of publicity now. It's www.cpstrust.co.uk, and there you can see pictures of Claire, who had spent years in institutional settings, now doing things like going sailing in the Solent.
Well, thank you very much, Jane. All of us, I think all the board had experience of this when we were involved in the NHS Citizens session in Leeds, and just getting that personal testimony of somebody who had been able to use a personal budget. I mean, Jane, I think two things. First of all, I mean, the board is wholly seized of the need to take this programme forward, and with urgency, and has been right from the beginning, because of the difference it makes to the lives of people, and the clear evidence that we have of its success. But secondly, it's complicated, but actually complicated is what we do, and this is complicated. Why? Because you're actually changing a quite significantly embedded bit of culture, and actually that's something that needs to be rolled out and replicated amongst many other things that we're doing. So we're right behind you, and we're going to keep pushing you, and we will wish to continually revisit the programme and measure progress. Good. If there are no other observations on Jane's report, may I just invite Simon to make a comment before we move to the next item?
Yes, sorry, it's not on that. It was just that characteristically I realise I understated the figure for the temporary staffing overspend. So for those in the Twitter sphere, it's not £1.4 billion of overspending on temporary staff. Last year it was £1.8 billion. So it was £1 billion in the FT sector, 800 million in the NHS trust sector, representing an £800 million year-over-year increase in temporary staffing expenditure. So 1.8 is what we're up against.
Right, okay, well, we'll absorb that. Thank you, Simon.